All right, everyone. I have 1 p.m. here, and it is my pleasure to introduce our speaker for today's virtual pathology grand rounds hosted by ASCP. Today we have Dr. Allison Chambliss, who is an associate clinical professor in the Department of Pathology and Laboratory Medicine at UCLA. She serves there as the Director of Laboratory Stewardship with a focus on optimizing the value of laboratory services provided by UCLA Health. In this role, she leads a laboratory stewardship program to support various laboratory, departmental, hospital, and health system initiatives and strategic goals. She's also a member of the department's clinical chemistry section, where she provides clinical service and training education. For today's talk, we'll be taking questions in the Q&A. So at the bottom of your screen, please use the Q&A option and place any questions there. And we'll leave time at the end for Dr. Chambliss to answer them. So thank you all for joining. And with that, I'll turn it over to you, Dr. Chambliss.
Thank you. Thanks so much, Dr. Wabker, for the introduction. And thank you to ASCP for the invitation and opportunity to speak to everyone today. I'm excited to speak about a topic that I'm particularly passionate about. And I have no relevant disclosures. So after my presentation today, I hope you'll be able to list the essential elements of a laboratory stewardship program, identify opportunities for lab departments to contribute to health system strategy goals, and describe effective strategies to influence test ordering. So I'm going to start with a bigger picture in establishing a need for laboratory stewardship. So many of you are probably familiar by now that healthcare in the US is evolving toward a value-based healthcare model. So this value-based care model is a model in which providers, including hospitals and health systems and physicians, are paid based on patient outcomes. So under these value-based care agreements, providers are rewarded for helping patients improve their health, reduce effects and incidence of chronic disease, and live healthier lives in an evidence-based way. And so this value-based care model differs from the traditional fee-for-service approach, in which providers are paid based on the amount of healthcare services they provide. So in the laboratory, we can start to think about ways that we can contribute to this value-based care approach by being more efficient and by improving quality while decreasing costs. And that bigger picture aside, we are all certainly feeling these strains within the laboratory. So many of us are facing issues like expanding and increased complexity of test menus and test volumes, mergers and acquisitions. Our health system just recently acquired a new hospital in our area, and these acquisitions typically lead to some sort of consolidation of lab services, often having to merge institutions that have different test menus, different lab instrumentation, different reference laboratories. And so we're typically being asked to handle all of this increased complexity while we are simultaneously facing labor shortages, frequent supply chain shortages. So in other words, clinical labs must do more with less. And before the era of laboratory stewardship that I'm going to discuss further throughout my talk, there have been other types of stewardship that have been embraced in and outside of the laboratory and with leadership of hospitals and health systems. And so the first example is blood product utilization. Due to its limited availability and high costs associated with transfusions, and the inherent risks associated with transfusions for the patient, these blood utilization committees have formed that have led to significant decreases in unnecessary transfusions, as well as improved patient outcomes. And there's also the example of antibiotic stewardship. So these efforts kind of similarly stem from risks both to the individual and to public health. So in other words, antibiotic resistance that come from the use of unnecessary antibiotics. And we know based on estimates from the CDC that there is a good amount of unnecessary antibiotics being prescribed. And so the CMS now requires acute care hospitals to implement antibiotic stewardship programs. And so a message that I want to get across today is that just like blood product stewardship and antibiotic stewardship, there is a place for lab stewardship as a permanent and standing initiative in the hospital and health system landscape. And not only is lab stewardship just the right thing to do, but laboratories are actually authorized to enforce it. So the Office of Inspector General, which is within the U.S. Department of Health and Human Services, they're tasked with fighting things like fraud, waste, and abuse, and aim to improve the efficiency of Medicaid and Medicare services in the U.S. And in 1998, this language was published in the Federal Register. It says that laboratories should take all reasonable steps to ensure that they're not submitting claims for services that are not covered, reasonable, and necessary. And further, if the lab discovers that it has in some way contributed to the ordering of unnecessary tests, the laboratory has a duty to modify its practice. So in a laboratory, how can we even start to think about monitoring test utilization, let alone changing ordering practices, right? So of course, it's going to take partnerships outside of the laboratory, and I'll speak a bit more to some of those examples later. But fortunately, there are now a variety of resources and guidelines available for laboratorians centered around laboratory stewardship and test utilization. So some examples are CLSI has published guidelines on how to develop a test utilization management program. And several other laboratory organizations, including ASCP and their Choosing Wisely partnership, have provided several test-specific recommendations. So these are typically recommendations of how a certain test should or should not be used. And these can be a great tool to start conversations at your own institution around lab stewardship with specific examples. There are also these kind of higher level guidelines for how to start and maintain a laboratory stewardship program more broadly, both from CLSI and also from PLUGS. PLUGS stands for Patient-Centered Laboratory Utilization Guidance Services. And if you're not familiar, this is a group based out of Seattle Children's Hospital that developed this institutional membership group. And they've really led the nation in this area of lab stewardship. And we are PLUGS members here at UCLA Health, and we've found the tools from PLUGS to be very helpful in starting and building our lab stewardship program. And so if you're interested in lab stewardship and building a lab stewardship program at your institution, I highly recommend these guidelines published in the Journal of Applied Laboratory Medicine from PLUGS. And so within those guidelines, they define these 4 essential elements of a lab stewardship program. So it's leadership, commitment, and governance, data extraction and monitoring, actions or interventions, and then to review and improve. So it's very similar to the PDSA cycle, if you're familiar with that tool of quality improvement, the Plan, Do, Study, Act. But essentially, as a lab stewardship program, we have simultaneously multiple PDSA style initiatives going on in different areas of the laboratory, each in different stages of the process. And I really want to emphasize this leadership, commitment, and governance part of these guidelines. So the importance of governance and buy-in this is a really crucial part of the laboratory stewardship story because effective lab stewardship, to be effective and to influence provider ordering behavior, it's going to involve changes to things like your test menu, possibly discontinuing tests or restricting the ordering of tests, and certainly the send out test formulary. And that's something I'm going to go into more detail about our story here at UCLA. Both laboratory-based and hospital or health system-wide written policies and implementing and enforcing those policies. And then we're going to talk about some tools for interventions, and a lot of them, especially the most effective ones, are going to be EHR, LIS based, kind of changing the way that orders are presented to providers in the electronic ordering system. So all of these things are not something that one person can change alone. And these changes typically have, kind of governance structures within a hospital or health system, and they're going to require high-level approvals, typically outside of the laboratory department. And especially enforcement of these changes is going to require cooperation by the ordering providers who are not in the laboratory department. So it's important to have this high level beyond pathology support, both to kind of get these changes through the health system and also to enhance the compliance. And so it's important to engage these non-pathology providers in the whole process. And so you'll see, and we have some examples of this, that when we have stewardship projects, we form multidisciplinary teams to have expertise for various clinical contexts and workflows. And once you've defined a lab utilization problem, the PLUGS guidelines also provide these various techniques for interventions. And so they're in the PLUGS guidelines are categorized as either gentle, medium, or strong interventions. And so they're increasing by strength and then also by likely effectiveness. So gentle would be something like passive provider order education, which is often easy to, or one of the easiest things to implement, but also usually not the most effective method in actually trying to change ordering practices. And then on the other hand, a strong intervention would be something like implementing hard stops in the order entry system. And so these interventions are likely to be more effective or the most effective, but they're also typically hardest to get buy-in to implement, because what I said on the previous slide, kind of like these layers of approvals and leadership that you have to go through to implement these sorts of things. And so I'm going to go over a couple examples of how we've used some of these techniques, both in the gentle and more in the strong categories in our stewardship program. But first, to familiarize you with our stewardship program, we have a committee called the Laboratory Stewardship Task Force that's composed of mostly pathology and lab medicine employees at various levels and across various disciplines of our department. So this includes faculty, lab managers, regulatory affairs. We have now 2 program managers that are assisting with our lab stewardship program that keep us organized and moving forward, which is really great. And this committee meets twice monthly to, really move forward the various projects that we have. Like I said, there's lots of ongoing projects going on simultaneously at different stages. And so it's a way to kind of keep us all organized and to delegate tasks and make sure that that projects gain and keep momentum. But then most importantly, we have that higher level support that I was talking about. And so quarterly, our Lab Stewardship Task Force reports out to another committee called the Laboratory Stewardship Oversight Committee. So this is a committee composed of key health system leaders mostly outside of the laboratory, mostly from the C-suite. So the chief medical officers of our hospitals and our ambulatory network, our chief financial officer of our health system and chief operating officer, and also the chief medical informatics officer, which has been a really key role in all of this because, like I said, a lot of our interventions are EHR based. And so the support of our CMIO has been really instrumental, I think, in our success thus far. And so this oversight committee serves to give approvals for various policies, new policies, policy changes, or other types of new initiatives that the task force wishes to implement. And then their approval, their kind of stamp of approval on these things that we present to them actually allows us to really most efficiently implement these policies, and also serves as a way to escalate policies or any sort of disagreements if necessary. This oversight committee also serves in an advisory role to help us prioritize our lab stewardship initiatives and to keep us aligned with the broader strategic goals of the health system. And so I do want to highlight that synergy between our program's goals and those of the broader health system. So at a high level, the goals of our stewardship program are things like demonstrating cost savings, initiating workflow improvements within the laboratory in terms of how tests are ordered and processed, improving patient outcomes if we can, most importantly, and then establishing clinician and community partnerships. And then these are the current goals of our health system. So they are enhancing patient safety and quality. And so this is specifically at our program, we use this movers model. So the goals are improving on the kind of benchmarks of mortality, outcomes, value, patient experience, readmissions, and safety. Also improving access to care, so things like improving patient flow through the emergency department, increasing the number of outpatient visits and the percent of new visits scheduled within 10 days. And often there's ways that the laboratory can contribute to these goals by having test results available faster to make patient management decisions faster. And then ensuring financial sustainability, of course, is a very important goal of the institution, and improving the overall operating margin. And again, this is something that laboratory stewardship can help contribute to. So if we can identify stewardship initiatives that are in line with these goals here, then these projects are likely to be supported at the highest levels and therefore are likely to be the most effective throughout our health system. So this is something that we keep in mind as we prioritize our initiatives. So drilling down more to concrete initiatives that we're actually doing, what does this actually look like for our program? So if we really strive to be patient-centric, then our initiatives will seek to improve patient safety and patient outcomes. And so we want to reduce risks of patient harm, such as when it pertains to lab testing, misordering, ordering unnecessary tests, either intentionally or unintentionally, ordering the wrong test, misinterpreting lab results, failure to retrieve and act on results. And we often have data to show that there are, significant rates of this going on. And then, of course, wanting to avoid unnecessary costs to patients and the health system. So if we seek to address these specific risks, then what we can aim to work toward would be things like avoiding duplicate testing, stopping erroneous errors, defining and implementing best practices or order algorithms where those exist in certain clinical contexts, making it easier for providers to follow best practices in terms of what tests should be ordered for certain diagnoses. Establish consistent testing practices across the health system. We are a complex, large health system, hundreds of ambulatory sites in addition to our 3 hospitals now. And so the lab stewardship program really aims to kind of have consistent testing practices across these different locations. And then I think the most challenging goal of all is to influence provider and ordering culture toward high quality, fiscally responsible practices. And so now I'm going to go into some examples of what we've done here. And I'm going to start with our really initial big focus of our laboratory stewardship task force. And so one of the first things that we did was to establish some oversight over our referral lab or send out testing process. So I would imagine that this is probably something that a lot of other institutions are struggling with as well. So some of the problems that we were seeing were that there was just some testing that was going to outside laboratories that was not being ordered in our EHR, that we didn't even know about, the labs that we didn't even know were being used as reference labs in our system. And so there are concerns there in terms of, one, just the lack of harmonization across the health system when it comes to use of reference labs, and also regulatory concerns, right? Like it's actually our responsibility. There's a CAP checklist item that establishes that the laboratory medical director is responsible for selecting referral laboratories. And it actually requires that the laboratory has a defined process for selecting and evaluating those reference laboratories based on the quality of their performance. So if we don't even know that they're using those labs, then there could be regulatory issues. I'll also note that we are in the state of California, and there's a state law that patient testing done on our patients the laboratory needs to have a California Department of Public Health license, even if they're not in the state of California. So we need to be vetting these laboratories for CLIA and California licenses. We also have this big problem of the miscellaneous test order. So I would again imagine this may be something that a lot of institutions offer as well. Essentially, if a provider wants to order a test to go to a reference laboratory and it's not available to order in our EHR, then they just go to this miscellaneous reference lab order and can free text what test they want and what lab that should go to. And so we called this the blank check. And so we really wanted to rein in kind of the use of the blank check, and I'm going to talk about that much more over the next few slides. And then, another problem with all this is that there's a lack of discrete data to monitor the test utilization and the associated costs with it. So if orders aren't being placed in the EHR, or even if they are, but they're miscellaneous and there's no discrete data associated with them, then we have, we don't know what we don't know. And so this is something we wanted to address. So our goals for this big multi-pronged project were to update and publicize our health systems referral lab policy and seek to enforce it, to establish a new reference lab test or new reference lab request and approval process, and also to address the use of these miscellaneous tests. So we wanted to actually look retrospectively at what tests are being ordered under this miscellaneous order and find the highest volume, highest yield ones and actually build them out as discrete orders in our EHR. But before we did that, we wanted to make sure that they were the right tests and that those tests were appropriate. And so I'll share a little bit about how we did that. So first was just to establish and kind of publicize this policy. This policy had existed for decades, but we took the opportunity to kind of refine it and really establish some key principles in governance of send-out testing. And so I've put here some of the key points of this policy. And again, this is a health system-wide policy. It's not just a laboratory policy. And so it really has that kind of like backing and support behind it of the broader health system. And so it applies to both the hospitals and to the ambulatory network. And so it establishes that all testing performed on our patients must either use an in-house laboratory or a reference lab that's approved by the laboratory director. And so we establish a list of approved reference laboratories. And another point was that if a comparable test is available at an in-house lab within our system, then a reference lab will not be used. And so if a reference lab test is requested for something that we perform in-house, some sort of compelling justification must be provided for that order. And then importantly, test orders must be placed in the EHR. So that was a big one as well. From there, we developed this form for providers to request new reference labs to be added to our approved reference lab list, and or for new reference lab tests to be built in the EHR's discrete order. So again, this is trying to address one, kind of just the governance and regulatory issues, and two, to try to get away from the reliance of this miscellaneous test order. So we were starting to encourage providers when they would express interest in new tests, or, sometimes what was happening is providers would enter tickets with our EHR internal, LAS EHR system analysts to add new tests to the EHR. And so those requests would then be redirected to this form. And so we would ask them to fill out, what specific test or lab they were interested in, and then some basic information like what is the general medical justification for this request, what types of patients is it going to be used on, what type of volume do we anticipate, and how much does the test cost? And we would work with providers to kind of find out some of these details if needed. And once this form was submitted, and I'm only showing a small portion of it here, but actually this QR code, I think, should take you to an active link because this form is actually publicly available and it's posted on our online test menu that is publicly available. So once a provider is directed to this to request a new test or a new referral lab, it goes to our laboratory stewardship task force that I referred to earlier. And we also kind of leverage subject matter experts either within our department or outside of our department to review requests as needed to really come up with the best decision of whether or not we should move forward with this new request. And so that was kind of the prospective approach of making sure that any new tests that are built in our system or any new referral labs that are they're added to our approved lab list are appropriately vetted. But we also wanted to kind of address retrospectively what was already being used, as particularly what was already being ordered as miscellaneous. And can we start to address that and start to build some of these, like I said, high yield, high volume tests as discrete orders in our EHR so that providers don't have to continue to use the miscellaneous. So we performed a retrospective review of all of the miscellaneous tests ordered in calendar year 2022. So this is something we could I say easily audit because they were orders placed in our EHR. We use Epic, by the way. I'm not sure if I mentioned that before. So we can pull a report of all of those orders. The problem is that they are free texted, right? The test that was ordered was free texted. So sorting through all of that data is very challenging. And so we're very fortunate that we have some great laboratory staff in our lab stewardship program managers who are very instrumental in this. And so there are actually, over 13,000 of these miscellaneous tests ordered across our entire health system in the calendar year of 2022, which corresponded to about 2,600 unique tests. And so we ranked those by volume. So we identified the top 100 most frequently ordered tests using the miscellaneous order. And you can see here on the right that we categorized them by different areas because we actually wanted to have subject matter experts in these various areas review these tests for appropriateness. So this is the first set of tests that we've addressed. So it corresponds to about a third of all miscellaneous orders placed that year. And test prices varied ranging from $13 to $800. Thinking about potential kind of like cost savings and streamlining orders here. And so then we funneled these 100 tests out to their respective subject matter experts, usually people within our pathology department who worked in, say, for example, my colleague, Dr. Omai Garner in microbiology, my colleague, Dr. Amir Matushi, who's our toxicology director and expert. I'm a clinical chemist, so by nature, I tend to get, all of these kind of like unclassifiable general chemistry types of tests, so that can be challenging, but I often would find providers in different specialty areas to kind of help me review and understand what the typical ordering pattern either is or should be for certain diagnoses, and that was very helpful. So we provided this spreadsheet to our subject matter experts for each test to fill out some details about just overall, is the test appropriate? Is it something that's performed in-house and therefore should not be allowed to send out? If it's not performed in-house and it is appropriate and it can and should be sent out, where should it go? Which reference lab should we use? Which specific test code should we use? A lot of these reference labs have very complex menus with lots of different versions of tests. And so we relied on these subject matter experts to help us find what is the best and most appropriate test. And then also to comment on whether if we do build the test, do we need some sort of provider order guidance, clinical decision support, or some sort of specialty restrictions or something to help with, making sure that there's not overuse of the test, because the fact of the matter is it's better to have the test built and to be discreetly available in the EHR. But once you make it easier to order, it also means it has the potential for, kind of creep of use. And so we want to be considering that as well. And if you're not familiar with this workflow of miscellaneous tests, I just want to take a minute to kind of highlight, why we really care so much about avoiding and redirecting miscellaneous tests to discrete orders. So when a miscellaneous referral lab order is placed, which we call kind of the current state, like I said, the provider has to free text which test they want and which lab it should go to. And so there's the question of, is that even an approved reference lab? And so actually the way that we've addressed this is that we still have the miscellaneous order available, but we designed a drop down where it's required that they have to select the performing lab from a drop down of labs that we've already considered as approved. We have to make sure that we have the correct test. Sometimes providers free text the test code, which is helpful. Sometimes they just write a generic name for a test, and then our lab assistants have to figure out what that means and which test was intended, and there can be some confusion there. Sometimes performing labs require their own requisition forms or patient history information or prior authorization. And so all of that, which can be kind of built into a discrete order, cannot be built in when it's a miscellaneous order. And so we have to figure out all that and make sure that we're addressing that for whatever test was ordered. When there's a built order in the LIS, we can provide the specific collection instructions, which tube type or specimen type is required, what the stability is. When you have a miscellaneous order, none of that is provided. And so often phlebotomists are having to look up these tests on reference lab websites and figure out what kind of specimen to order, making sure that we have the right stability instructions and that the shipment instructions are clear. Figuring out how to charge for a test with a CPT code that's not going to be built in to a miscellaneous order, and then getting a result back, which is going to be receiving a PDF from a referral lab and scanning it into the patient's record, and hopefully somebody sees it. But those can often be difficult results to find. So lots of problems with this miscellaneous order workflow. Versus if we are able to identify these high yield tests and build them as discretely orderable, then it's very easy for the provider to order the test. We cover all of these issues about, specimen processing, collection instructions, if there's any sort of additional paperwork that's needed. And then, in most cases, we're going to be using a lab that we're electronically interfaced with. And so we can just skip straight from placing the order to a couple of days later. Usually the result is just interfaced back into our EHR. Care Connect is our version of Epic. In some cases, we do need to use a lab that we're not interfaced with. So we would need to have that upload result step. So that is something to consider, but you can see that this is a greatly streamlined and improved process and can help avoid a lot of the issues, errors, delays, and cancellations associated with the miscellaneous workflow. And so we've gone on a little bit of a kind of campaign to our providers as we've gone through this project to really emphasize the benefits for all if they use these built orders, and if they will come to us to request built orders rather than continuing to rely on miscellaneous test orders. So there's benefits for all, both the patient, the provider, and the laboratory. You can see some of those here. I kind of spoke to kind of streamlining the processing workflow, decreasing avoidable errors. It's good for the provider because it's just easier to order, and then also easier to find the results, and can decrease this unnecessary repeat testing that happens when people can't find the results in the EHR. And then for the patient, most importantly, we can minimize avoidable cancellations and redraws, faster, more efficient phlebotomy service when the phlebotomist knows exactly what test is ordered and what specimens they need to get, improved access to interfaced results through MyChart in our case, and then the reduced potential for out-of-network billing if we are using these kind of approved reference labs through our system. And with any initiative, it's important, I've spoke to what all those hypothetical benefits are, but it's important that we try to collect our own data on the impact of our efforts. And so we are still in kind of the very early stages of this big project, and we've built, I think, like 30 to 40 tests from this miscellaneous, retrospective miscellaneous test review, and we're continuing to build those out. This is just some initial data from, I think, the first 5 tests that we built through this process. So we were looking to compare how the newly built tests were being used versus providers continuing to order as miscellaneous, which is still a possibility. We have lofty goals, I would say, of eliminating the miscellaneous order option completely once we build out all of these tests, and we can kind of manage more in real time any requests for other tests to come to the laboratory. But until then, we do still need to provide the miscellaneous order while we're still working through this. And so that means that people, once we build tests, people can still use the miscellaneous order. So with those, benefits that I spoke to on the previous slide, we're really trying to educate providers on using the new tests. And here we've just shown some data about the uptake rate. So the uptake rate is 6 months after the test was built. In those 6 months, what % of the orders came through as a discrete order versus the total orders, which includes both discrete and miscellaneous orders. And so you can see, like, overall, we have a 64% uptake rate of the new tests. with some tests, kind of immediately being adopted versus others, kind of a slower uptake rate, people still relying on miscellaneous orders. And I have some speculation as to why, some of these tests are more easily adopted than others. And I think, some of it has to do with the complexity of the reference lab menu and how tests can have similar names. For instance, if they're looking for a SARS-CoV-2 test, they're not going to find it under COVID-19, and they may still be using the miscellaneous, just as an example of why we might be seeing some miscellaneous orders still. But we are working to educate providers about the new tests, and also want to mention the turnaround time. So these newly built tests, at least in these 5 cases, are going to a reference lab that we are electronically interfaced with. So this avoids those steps of, scanning in a PDF from the reference lab. And we were actually able to see immediate improvements in turnaround time when the new discrete orders are used by an average of about 1 day. So the result is posting 1 day faster in the EHR for these cases. And like I said, we really need the providers to use the new test. And so one thing that we've done to try to enhance that uptake rate is provide targeted provider communication by these emails. So we are finding providers who have specifically ordered in the past these tests via the miscellaneous route. Rather than this just going as a blast to every provider in the system, we're sending specific targeted emails to those providers who've ordered the test historically. We actually, with our program manager, has made this automated email tool that's able to run a report of who's ordered it in the past and then send the email to those providers, which has been really helpful. And so you can see here, we're trying to spread the good news that we have an easier way for the provider to order the test. And then we provide the specific test name and lab code for them. And then with my remaining time, I'll go through just a couple more examples of other things that we've focused on or tried in our laboratory stewardship effort. So one of them is what we would call cost transparency. So this is the idea that perhaps if providers knew, and this is again focused on send out testing, if providers knew that a test, was a send out, because many times they don't know, right? They just see that they find the test that they need, whether it's in-house or sent out, doesn't matter. And they have no knowledge of where that test is performed, right? So the idea is that if they knew that it was a send out, what the expected turnaround time is, and also what the cost is, that could potentially avoid some unnecessary orders. And so I would categorize this in that plugs, guideline, gentle or passive category, where this is not an alert or a pop-up. This is just something that sits in the test menu next to the send out test name. And so we've identified it as a send out, the cost, and the expected turnaround time, which is what's published on the reference lab's website. We've tried it a couple different ways. We've tried actually putting the actual cost of the test. This can be difficult to keep up with because those costs can change. So maybe another more approachable way is to use these cost groupers, where we just kind of categorize tests based on these cost ranges and then have $1 to $4 signs. So this is, a nice way to hopefully nudge ordering behavior, but also avoid those intrusive, pop-up alerts that can be difficult to get through governance. And so we're looking for more kind of creative ways to influence behavior without having so many alerts. And so this was one thing that we tried. This was actually published by our group here, if you're interested in the publication. And so they did observe some decrease in send out cost spend, particularly in the inpatient setting relative to the ambulatory setting, once they implemented this cost transparency idea for send out tests, but it was actually not statistically significant. And so if you, from the paper, if you read it, they concluded that, since this intervention did not provide alternative test options, in addition to the test orders maybe being placed at a later step in patient management with kind of, no other options, and also orders being facilitated facilitated by trainees or mid-level providers, all of these things may have limited the effectiveness of their intervention. We are still continuing to display this information on send-out tests because it's relatively easy to do and at the very least can't hurt, and may help in reducing some unnecessary orders. Another thing that we're trying is what we're calling order frequency alerts. So this is something that many other institutions have described successes with. So the idea here is that, you could probably think of some orders that or some tests rather that are not necessary, more frequently than a certain time period. So a classic example of this is hemoglobin A1C, which is reflective of the patient's glucose control over the prior 3 months of the sample collection. And so, getting a hemoglobin A1C monthly, for example, it's unlikely to change significantly. And so, certainly something that shouldn't be ordered daily or weekly, if not, monthly. And so there are other examples, for instance, an HCV antibody test, which is going to be positive for life if a patient ends up being positive. And so, getting repeat tests is probably unnecessary. So these are just a couple of examples, and we haven't actually implemented these here, so I don't have any real world data yet, but there are several examples in the literature that have. But we've proposed to start with these 5 tests, and what we do have in terms of data is the projected savings, actually using historic data to find how often, say, is a lipid panel ordered more than once in 30 days. And so the answer was 5.7%. And so if we can provide information upon ordering of the repeat test to notify the provider that the patient already has a lipid panel on file within the last 30 days, and these are the results of that prior test, with a kind of a default selection of removing the current order. And this is a soft stop, so they could choose to keep it, but the default option is to remove it. And so we are actually designing and kind of testing some of these alerts right now and hope to have some more real world data. But we kind of saw this as kind of a low hanging fruit type of approach. It was pretty easy to get buy-in for these alert intervals. And so I'm interested to see how well this will go. Some other things you can think about, and these are hypothetical examples, but we have tried some versions of these, would be order restrictions by specialty. And so if you can get, if there's a particular test that you're seeing being over-ordered or misused, and you can, have a discussion with the clinical leadership of the particular, area that testing tends to fall under clinically, it's often a good and approach to restrict orders by specialty, and this can typically be easily done within the EHR if you want to go that far and you don't want to be actually manually screening orders for who ordered them. So I think the EHR restriction is a better approach if you can get that buy-in. And so some examples might be orders for autoimmune neurology panels, like these autoimmune encephalopathy antibody panels that typically cost over $1,000, must be ordered by a neurologist. Orders for serum allergen testing versus skin testing. CMS has some strict requirements around, when serum testing can be performed, because usually in most cases, skin testing is supposed to be the preferred approach. And so these orders must be placed by an allergist or a pulmonologist, or something like clinical exome sequencing requiring genetic counseling prior to processing test orders. One thing we have implemented here that's related to this idea is, and this is the work of my colleague, Dr. Josh Dignan, who's in our molecular pathology laboratories and co-chairs our stewardship committee. This is restricting genetic testing in the inpatient setting. So inpatient genetic testing can be problematic in some scenarios because it tends to have long turnaround times. We have data to show that results typically come back after the patient's been discharged and may not change medical management. And also this testing can be expensive and is typically not reimbursed for inpatients. And so it's a revenue loss for our health system. So we have identified a list of genetic tests that if ordered in the inpatient setting, the provider would get this alert to notify them that ordering that specific test on an inpatient requires a consult to the molecular diagnostics laboratory director who would review the case. They have kind of a policy and list of criteria of when testing may be indicated versus not in the inpatient setting. And if they can come to an agreement that the testing is indicated, then they can push this order through. And so Dr. Dignan will be, I think, further describing some of this data and publishing this data in the near future. And we've already seen some good successes from this workflow that we've had in place for a couple months now. And then I am a clinical chemist, and most of what I've talked about today is on the lab med and CP side, but just wanted to be mindful of anyone who may have interest in stewardship in the anatomic pathology area. We are seeking to grow and enhance our stewardship program to focus on some utilization issues in anatomic pathology. And so I'm not an expert in this area, but these are just some of the kind of utilization questions that have come up that we're just starting to address here. So one is things like thyroid FNAs. Are there appropriate indications for biopsies if nodules are less than 1 centimeter? And then a lot to do with send out testing on tissues, especially molecular testing. So this can be for the thyroid, FNAs, or for other areas. So, similar to the oversight of reference laboratory testing I described earlier, which was really focused on kind of liquid-based samples coming through our core laboratory, we also want to have this oversight and, make sure we're approving the laboratories that are used for tissue send-out testing, and making sure that we have discrete data that orders are placed through our EHR. And we've also discussed, and I think this is kind of a popular topic right now in terms of stewardship, is flow cytometry. So reviewing medical necessity, indications, and the appropriateness of kind of the degree or number of markers that are used in panels. And then finally, I also want to mention that, again, most of what I focused on here is seeking to address overutilization of testing, but it is important that lab stewardship also addresses underutilization and equitable access to care. It's all about making sure the right patient gets the right test. And if a particular test is overused or not appropriate, there may be another test that is, and we want to make sure the patient gets that test. So I do want to mention, ways that lab stewardship programs can address underutilization. One way would be through the National Committee for Quality Assurance's Healthcare Effectiveness Data and Information Set, the HEDIS measures. So this is a tool that's used by more than 90% of U.S. health plans to measure performance of healthcare services. So examples could include making sure that children are being appropriately screened for lead, that women are being appropriately screened for cervical cancer, and that we are screening for kidney disease in patients with diabetes with tests like the eGFR and the urine albumin to creatinine ratio. Another way that you could think about this is with guidelines compliance. So if there are clinical guidelines that establish, certain patients within a certain kind of diagnostic cascade should get a certain test, lab stewardship programs can help, enhance and prompt that testing to occur. And so one example we've thought of here is including serum-free light chains in the initial evaluation of monoclonal gammopathy when serum protein electrophoresis is ordered. And so I'll close here with just some final thoughts of, what's worked well and what's been challenging for us in our stewardship program. So what works well is that we have a multidisciplinary lab committee, that high-level oversight that I mentioned, clinical leadership and clinical champions for various initiatives, that our department is included in health system strategy planning and really has a chance to align our efforts with the broader strategic goals of the health system. I mentioned our program managers who are dedicated to our stewardship, quality, and EDI areas, and serve to better align those areas in our department, and that's been very instrumental. And also our clinical faculty who have designated time for example, myself in stewardship, in quality, and our informatics faculty have been really great in moving some of our stewardship initiatives forward. Remaining challenges include Um, like I said in the beginning, kind of you don't know what you don't know, and we're trying to address these send out orders that are going around us, but it's hard to even know that they're happening and then to kind of address them from there. We are building out more send out tests in our EHR so that people don't have to go outside of the EHR to order them. And so that's helpful in addressing that. I also mentioned we have an expanding health system footprint. And so that's always challenging when we have a new location or new hospital, and we kind of have to get them in line with these policies and workflows that we've established. Access to data can still be challenging. It's always important to have data to show that there is a stewardship problem, and then to monitor a stewardship intervention's effectiveness. And so that's getting better for us, but still sometimes is a challenge and can be slow. And then, we want to quantify our successes, do a better job at demonstrating actual cost savings, which again can be challenging, I think, because of access to data and access to billing data, for example. And also we want to do a better job at benchmarking. We don't really have good targets necessarily for interventions of like what is appropriate utilization. But I think, and Plugs is helping with this to establish some benchmarks across institutions in a kind of a normalized way. And so that will be helpful in kind of determining how successful we are, and also sharing our successes with our hospital leadership. And so here are just a couple acknowledgements. It really is a great team here at UCLA when it comes to laboratory stewardship. Our department leadership and lab stewardship teams, also our broader clinical leadership across the health system, and for sure our informatics team. So with that, I will close my presentation, and I'm happy to take a couple questions.
Thank you so much, Dr. Chambliss. That was a really great and comprehensive discussion about lab stewardship. I'll make a couple comments in case people need to hop off before the questions. You will receive an email from ASCP with instructions on how to claim credit for this presentation. And also within that will be a link to the recording. So we won't have the slides available, but you will be able to view the recorded session so that you can come back and revisit some of these topics. So again, please put any questions you have for Dr. Chambliss in the Q&A. I did just want to mention a couple more comments than questions. I really appreciated the kind of common sense approach to putting in things like the costs of the test, and it's almost like seeing calories on a menu. Like you have to be a little more circumspect before just clicking yes to it. So I wondered if there were any other sort of common sense things that you didn't get to mention that might be easily applied.
Yeah, and like I mentioned, I think we're in a point where we really have to get creative with our approaches. Like nobody wants more pop-ups and alerts, and we are just one department in the grand scheme of the health system, and the IT epic for us is getting all sorts of requests from other divisions and departments, because they're kind of doing similar things in radiology or in pharmacy. And so providers are constantly inundated with these pop-ups, and so they really want to limit them to what is truly needed. And so that kind of leaves us with like, okay, what else can we do if maybe a pop-up isn't really warranted in the situation? So one thing that we've thought about is we call it like passive order guidance. So kind of like having little one-liners like under the test name, or like a classic example would be like two tests that maybe sound similar or kind of get mixed up. And so like the classic example of this is vitamin D in clinical chemistry. So there's a 25 hydroxy vitamin D and a 125 dihydroxy vitamin D, and one is commonly indicated and one is rarely indicated. And so we put like common and rare next to the test names, or like, a short one-liner description of like what the test is used for. Another one that this is a clinical chemistry example as well, but we're trying to improve simultaneous orders of two breast cancer antigens, CA15-3 and CA2729. They're both clinically equivalent, but we see like a high rate of double ordering. And so trying to provide like a short guidance of, like test is clinically equivalent, only need one. And so that's like not a pop-up, but it's something that can go kind of like right under the test name. So those are kind of the other kind of simple, easy to implement interventions that we haven't received, much pushback about. Now, like as to how effective they really are kind of remains to be seen, but at least it is something.
Yeah, I like that it's both educational and stewardship
Mhm.
if people actually read it. All right, we have a question from Fiona Craig. When you ask clinicians to request a consult for molecular testing, do you bill for the pathology consult?
That is a great question. So right now we are not billing for those consults, and it's our molecular diagnostics lab has a mix of MD and PhD directors, and so there's an issue there in that we can't be billing for the PhD consults, and so for that reason we are not currently billing for those consults, but it's something that we are interested in exploring, and I think we were really excited about that workflow and that it could be, it could be leveraged in other ways. I kind of have a dream of once we kind of get this miscellaneous testing under control and get it to a manageable level that it can be reviewed in real time, we could have kind of a similar workflow where like we would have kind of an active case review process for tests that are requested that are not built in our EHR. And so I would love to have some sort of like, consult approach there, but no, currently we're not billing, but potentially interested in exploring that.
Yeah, I think that's really important to kind of position ourselves where we should be, which is the experts on the testing instead of being told to just carry out something that
Yes.
someone else has selected. So I
Yes.
hope that does get some leverage in your institution. Have you, from Dennis Adams, have you encountered issues with send out tests that is not available at a reference lab with a California license? And if you do, how do you tell the provider?
Yes, yeah, absolutely. This has happened a couple of times. And so our first step would be to try to find an alternative lab that, offers the same or equivalent or similar test that is California licensed. The area that I think this has been the most challenging is often in like pediatrics and rare diseases, where there's maybe one children's hospital in the US that we can find that runs a certain test. And so in that case, we have try to work with a performing lab to guide them through the California licensure process. And kind of the incentive there is that if they were to obtain the license, like we would be able to send our samples to them, and other California institutions could send to them as well. So I think it helps like getting other if, for example, the UC system, if we can, get the kind of the agreement that, yes, we would like to use your lab. And, usually it's rare diseases and the volumes are low. So the yield for the performing lab can be challenging. But that's kind of the approach that we've taken, but it is a challenge.
Have you ever turned that around when you're struggling to find a place as an argument to have some of the esoteric testing in-house so that you become the reference lab?
Yeah, yeah. I can't think of an example in the recent past, but yeah, that's a great point as well.
Yeah. Okay, one more question. Do you have a clinical champion to support your lab medicine formulary committee?
So we don't have a specific clinical champion other than we do have one non-laboratory provider on our lab stewardship task force, which is our lab-based committee. So that's the committee that reviews those. And so she's the medical director of our managed care system. And so often is able to kind of provide that external insight. But usually if there's kind of like a challenging request or a request that we don't think want to approve, we would go to the clinical leadership of the applicable area. So we've done this in cardiology or neurology recently. And so we typically aren't just flat out denying a request without having that conversation. And so those are people that are not sitting on our committee full time, but that we kind of approach on an ad hoc basis.
Yeah, I'm sure that's made a lot easier with your tracking and being able to look at what sort of tests kind of keep coming up as, problem areas. So, well, I think that's great timing. It brings us right to the hour. So, Dr. Chambliss, thank you again. Really excellent talk and good discussion. I will let everybody know who's still on here that our next virtual pathology grand rounds will be held on December 4th, and that's a Wednesday. It'll be at noon Central Time again, and it's Dr. Ivan Gonzalez who will talk about a practical diagnostic approach to neonatal cholestasis. So 180 from where we were today, but I hope many of you will join. And again, thank you, Dr. Chambliss and ASCP for hosting our virtual pathology grand rounds.
Thank you all for attending, and thanks again for the opportunity.
All right, have a great day.